All right, it's just waiting for the queue to get going. So absolutely fantastic to see you here. Thanks so much for coming along to what I think is going to be a fantastic session. So for those of you who don't know me, my name is Aziz Sheikh. I have the privilege of leading the Nuffield Department of Primary Care Health Sciences. And we've recently instituted a guest lecture series, and absolutely delighted that we're going to be kicking off with Sir Richard Peto. Richard being a giant in his field. I'll say a bit more about Richard in a minute, but just to kind of give you an overview of what we're planning to do. So very, very grateful to you all for turning up. You see this is a packed house. Thank you to everybody also who's joined online. Delighted to have you here. We prefer you to be here. So for those of you online, the chat is disabled. There's no opportunity for questions. But nonetheless, absolutely fantastic to have you here. So the plan is, after I've said a few words, I'm going to hand over to my colleague Nicola Lindson, an Associate Professor in Primary Care, who leads our Oxford Tobacco Addiction Group. And then we've got a series of lightning presentation from the Oxford Tobacco Addiction Group, or OxTAG as it's known, with a short Q&A. And then we'll move over to the main event, which is Richard's lecture, Tobacco Deaths, the Past 75 Years and the Next 75. And then we'll have a Q&A with Richard, and Richard's very kindly going to stay around for lunch, so there's an additional opportunity to kind of catch up with him there. And very, very grateful that Prabhat is joining us, Prabhat Jha, the new head of our sister department, the Nuffield Department of Population Health. So this is very much a kind of a joint event, the coming together of these two fantastic departments, the first of many such events. In terms of housekeeping, the fire exits are kind of clearly marked. There are no tests planned. So please, I think just congregate upstairs, follow the signs. If anybody needs the washrooms, they're just to my left for both men and women and accessible facilities. So again, absolutely fantastic to have you here. A really important subject. Sometimes it's getting neglected, inappropriately so. I'm really pleased that we're going to be giving a devoted session to the really important subject of tobacco addiction. And I'm going to hand over to Nicola, really, just to say a few words around the OxTAG group. So Nicola, over to you, please.
Thank you very much, Aziz, for inviting us to be part of this session. It's really exciting. And yeah, as Aziz said, the team is just going to give a kind of brief overview of the work that we do within OxTAG. I'm an associate professor within the primary care department and the lead of the group. So here we all are here, and all of us are here today apart from Andrea, who is based in Abu Dhabi. And just to say in the first instance that we don't take any funding from the tobacco or vaping industry. Important. So first off, to give you a bit of a historical aspect on this. So research in this area has been going on for a long time in the primary care department. So I'm not sure whether this is the very first paper, but the paper on the screen here was published in 1984 in the BMJ, and that looked at behavioural interventions for stopping smoking. In 1996, the Cochrane Tobacco Addiction Group was established within the department. For those of you who may not be familiar, Cochrane's aim is to carry out systematic reviews of healthcare interventions to establish the benefits and risks of those treatments. And the Cochrane Tobacco Addiction Group was one of many topic-specific groups based around the world where we carried out our own reviews, but also helped other people to carry out their Cochrane reviews and offered a kind of editorial function as well. Now, in more recent years, the way Cochrane does editorial has changed, so none of us within the group carry out that editorial function anymore, but as you'll hear in a moment, we do still carry out a lot of Cochrane reviews. So that's kind of to say that originally when this work was being done in the department, there was a big focus on examining the safety and effectiveness of smoking cessation interventions in the general population. But what has happened over time, certainly since 1984, is that smoking rates have gone down substantially. But what we know is that those people who are still smoking are those who are most dependent and who find it most difficult to quit, and that is creating massive health inequalities due to the adverse effects of smoking. So our work now is a bit more focused on looking at kind of new products that are coming on the market that might help these people to quit, and also to focus specifically on those groups that are disproportionately affected. So to give you a very quick overview, in terms of interventions, we're doing a lot on emerging nicotine products such as nicotine vapes and nicotine pouches, as they may be more appealing to these groups. Also smoking reduction, as opposed to quitting smoking abruptly, as some people find it very difficult to quit abruptly, and offering opportunistic brief advice in a range of different settings to try and increase access to these treatments, and also to increase the motivation of people to quit smoking, hopefully. So we've got work going on in specific groups, such as people experiencing financial hardship, people with chronic and long-term conditions, including mental health conditions, and also people in a variety of cultural communities. We have 3 DPhil students, so Anika, Andrea, and Ethan, and they're conducting work in socioeconomic inequalities, cultural tailoring of interventions, and the role of mood in relapse to smoking and vaping, respectively. Now, I won't read off all these methods on the slide here, but we do use a wide range of methods, and we have expertise in both quantitative and qualitative methods, and you'll hear a bit more about the specific projects and methods we're using in a moment. But one thing I really wanted to focus on is across all the work we do, we really try and maximise dissemination and therefore the impact that our work has. So I was just going to go through a few ways that we try and do that. So we really try and engage with healthcare guidance developers, and for that reason, a lot of our reviews have been published in worldwide healthcare guidance. We also really focus on trying to disseminate our findings to healthcare professionals, practitioners. So, for example, this year we spoke to the Lithuanian Centre on Addiction and at the World Conference on Lung Cancer. You'll hear in a moment we carry out service evaluations, so part of that is feeding back to local authorities and other organisations to tell them about what's working well in their services and what might be able to be improved. We respond to consultations, so at the minute we're in progress in working out a response to the open call for evidence on the tobacco and vapes bill, which is currently going through the House of Lords. And one of our biggest achievements this year was that we found out that one of our Cochrane reviews had been cited in the successful application for the smoking cessation drug cytosine to be added to the WHO list of essential medicines. So that was something that we're really, really proud to hear. And as well as academic institutions, we also work with non-academic institutions such as the National Centre for Smoking Cessation, the National Centre for Smoking Cessation and Training, the Royal College of Physicians, and the Action on Smoking and Health. We include them in our grant applications, but we also help them in developing training and contributing to their reports and things like that. So now I'm very happy to hand over to the rest of the team for a kind of whistle-stop tour of some of the projects that we're working on.
Hello everyone, my name's John Livingston Banks, and I'm going to be talking to you about some of our efforts doing systematic reviews and evidence synthesis related to tobacco control. So the long and the short of it is we do loads of them. We do loads of systematic reviews. A quick count based on members in the current group, we found at least 60 reviews that have been authored by group members. And we've also had extensive work through the Cochrane Tobacco Addiction Group. Nicola and I were managing editors, and I was also the information specialist. We have a comprehensive coverage of different topics. We've done systematic reviews looking at behavioural interventions and a range of pharmacotherapies, pretty much covering almost every kind of intervention you could be interested in. I mean, I could go on. So I will. We've also looked at complex questions related to dosing, duration, modes of delivery, specific populations, the health impacts of quitting, and non-combustible products like smokeless tobacco. And this, again, is just a fraction of those reviews. I seriously could go on. So I will. We've also conducted network meta-analyses and component network meta-analyses that give us comparative effective estimates. So we don't just know what works in both behavioural therapies and pharmacotherapies, but we also know how they work related to one another, and we're also able to do work identifying the components that impact how effective those interventions are. And yet I still could go on. but that joke is played out, so I won't. But seriously, like, we do so many of these reviews, and we can't stop. And you don't want us to, because our reviews impact practice, right? Our reviews are cited in national guidelines in these green countries. This was just based on a quick look on a rainy afternoon, as well as pan-European and global organisations like the World Health Organization. And some of our most recent work is collaborating as part of a Centre for Assessment of Tobacco Regulation, TCOR's CASTR, which is working directly in response to FDA policy needs, and allows us to do directly responsive work that feeds directly into their practice. Some of the current topics that we're working on in aid of this are reduced nicotine cigarettes, heated tobacco products, and we also have some ongoing work on e-cigarettes, for which I will hand over to my colleague Elsa.
Thank you very much, John. And so Living Systematic Review process was first proposed in 2014. And these are reviews that are continually updated, incorporating relevant new evidence as it becomes available. They're labour intensive, and you need to know when this is justified. So they are suited to fast-moving policy relevant topics where there's uncertainty. They have the same rigorous and recommended methods used in standard Cochrane systematic reviews. They provide a unique opportunity to incorporate stakeholder feedback, and timely updates and dissemination allow stakeholders access to recent evidence for decision making. So the LSR methods are well suited to the relatively recent, fast-moving nature of e-cigarette or vape research. So we have transitioned 2 of our reviews to living review status. Our e-cigarette for smoking cessation review, which aims to examine the effectiveness of e-cigarettes to help people who use tobacco cigarettes to stop compared to other stop smoking tools. This review became a living review in 2020. We've published 6 updates since then. The most recent one was just published last month. This review became a living review in 2020, as I say. So the newer interventions for quitting vaping review assesses the benefits and harms of interventions to help people stop vaping and how these interventions affect tobacco cigarette use behaviour. Do people go back to cigarettes? Do they transition or whatever? So this became a living review after first publication in January 25, and an update is about to be published. There's still uncertainty in the evidence and unanswered questions. So in the newest update to the EC for Smoking Cessation Review, we now have 104 included studies with over 30,000 participants. And here we have many comparisons and many outcomes, but here I'll present results for smoking cessation at 6 months or more for the comparison of nicotine e-cigarettes versus NRT, nicotine replacement therapies, that's patches, gum, etc. So for this outcome, we have high certainty evidence that nicotine e-cigarettes help people to quit at 6 months more than NRT. There are 9 studies and nearly 3,000 participants contributing to this outcome. So the high certainty evidence means that for this outcome, we're very confident that the true effect lies close to that of the estimate. And so dissemination, lastly, is an integral part of our LSR process. We produce briefing documents for the 2 reviews, both a plain language and a healthcare professional and policymakers versions. These are all updated monthly with our search findings. And in our monthly podcast, the new research is summarised, and we interview a researcher involved in an eligible study that's just been picked up. So here's a link to our continuously updated Living Review website, where you'll also find our open access reviews, monthly search findings, infographics, videos, and many more materials. Thank you very much. I'm very happy to hand over to Annika.
Hi everyone, my name's Anika and I'm a doctoral student with the team. I, alongside Angela, are going to talk about socioeconomic inequalities in smoking, some of the work that our team is doing on that. So in the UK, people from lower socioeconomic groups are more likely to smoke, and greater smoking prevalence translates to disproportionate tobacco-related disease, making tobacco smoking a major driver of health inequalities. My doctoral program of work, which was funded by the Society for the Study of Addiction and the Rotary Foundation, aimed to investigate socioeconomic inequalities in smoking cessation behaviours and outcomes, with the goal to reduce health inequalities caused by smoking-related disease. I completed 3 projects. The first was a Cochrane systematic review, where I looked at the differences in effectiveness of individual-level smoking cessation interventions by socioeconomic group, and also categorised the potential impact of these interventions on health inequalities. There was no clear evidence to support the use of different individual level smoking cessation interventions for people from higher or lower socioeconomic groups, or that any one intervention would have an impact on health inequalities. For my second project, I collaborated with University College London and used cross-sectional population-level survey data from the Smoking Toolkit study to investigate associations between 5 different indicators of socioeconomic position and smoking and quitting behaviours. In England, I found there was consistent evidence that people experiencing greater disadvantage are substantially more likely to smoke. They have high levels of tobacco addiction and are less motivated to stop smoking or make a quit attempt. And these findings were consistent across different indicators of socioeconomic position. My third and final project was a multi-method service evaluation of a new stop smoking scheme offered to people experiencing financial difficulty. I worked with a local county council, a UK charity that provided free financial support advice, and a local stop smoking service to evaluate this new stop smoking scheme that included very brief advice and financial incentives to help people in financial difficulty quit smoking. This is one of many service evaluations conducted by our team, where we work with different local authorities, charities, and stop smoking services, and Angela will speak a bit more about some of our work on that now.
As Anika has already mentioned, people in more deprived areas are a lot more likely to smoke. And what we do know is that very brief advice works in clinical settings. And what we want to know is, can we translate that across into new settings? Now, with the rising tobacco costs, that means potentially there is a new motivating factor, which is the financial burden. So the first question is, what is very brief advice? Very brief advice is typically a 30 to 60-second conversation where the idea is you first ask the person, are you smoking? And then you advise them on the most effective ways to quit. And most importantly, within that conversation, you act and you offer support. So whether that is a direct referral to a stop smoking service, to a digital app, and so on. So what we have done is working with our partners in Greater Manchester directly at looking at social housing. We've created and co-designed with residents, housing and health partners to find out what kind of interventions would you like within social housing settings. And what our partners selected were 2 different approaches. The first approach was to train community voices, so new voices, people who are embedded in that community, in that very brief advice, in that 30 to 60-second conversation. And the second approach that came out was they wanted to try something like a digital campaign, which is region-wide across Greater Manchester. And the idea was called Stop Smoking, Start Living. Now, right now, both of these are currently in process, and we are looking forward to evaluating. But what I can show you is some of the images that we came up with, which are currently being displayed across Greater Manchester, with the focus primarily being on the positive choices and gains that you can get from stopping smoking, but also not necessarily to do with health, but to do with finances or to do with other personal aspects of your life. And please do not distribute these images without any permission. Thank you. And then next up, we've also looked directly at integrating very brief advice into social housing policies. So as Anika mentioned, financial support services are one avenue that we're looking at. And with Clarion Housing, their charitable organization Clarion Futures, we've tested whether or not very brief advice in these financial settings is feasible and acceptable. And what we have found is that both residents and the officers delivering this advice were very happy with the introduction of this. We found that there were modest quit rates and they were better than unaided attempts. And this implies potentially that this could be worthwhile for us to try and test out. And what does that mean? It means the next step is to scale that up, which is currently what we're doing. We are being funded by the NIHR to run a trial called Savings, where we're looking at smoking cessation advice in financially vulnerable individuals accessing financial support services. And working with our partners on screen right now, our hope is to test the feasibility, effectiveness, and cost effectiveness of this, focusing both on smoking and financial well-being. And that is the wrap-up in terms of social housing. Thank you.
As Angela just touched on with the savings trial, our group are involved in working in applied tobacco research, with many of us developing behavioural interventions that go on to be tested in clinical trials, which I and my colleague Jack will now talk a little bit about. We're particularly interested in harm reduction and the idea of giving people an alternative approach that reduces the harms of smoking, particularly in those who find it difficult to stop smoking altogether in one go. That's especially relevant for certain population groups, for example, people with chronic conditions or serious mental illness, who often have some of the highest smoking rates and for whom stopping smoking would bring huge health benefits. So while these groups might find it particularly hard to stop, they may need a different approach to stopping, like cutting down gradually on the number of cigarettes they smoke while being supported to reduce with appropriate treatment options. As we heard earlier from Elsa, there's good evidence that e-cigarettes can help people stop smoking, so our trials are exploring whether they might also support harm reduction in these higher risk groups. In one such trial called the MASK study, we trained GPs and nurses to give very brief advice and offer an e-cigarette to patients with multiple chronic conditions who didn't want to stop smoking, to see whether they'd be willing to switch to vaping instead. And we found that 90% accepted the offer from their GP or nurse. We compared this with a group who received standard stop smoking advice and found that after 2 months, 20 of those offered an e-cigarette had halved the number of cigarettes they smoked, compared with only 6% in the usual care group. Now, not many of those went on to quit completely, which we think may be because the e-cigarette group didn't receive behavioural support, which we know is something that boosts people's chances of quitting. So there are some questions that remain unanswered, but we know that this type of opportunistic intervention shows a lot of promise in these settings.
So, we have evidence that this approach of offering an e-cigarette to people who decline smoking support is effective in primary care. But could it work in other contexts? Like Rachna said, people with serious mental illness have much higher rates of smoking than the general population, and this is a major cause of the health inequality that they face. Could the MASK intervention be effective here? We have an NIHR programme grant called Trident to test in a clinical trial whether we can do this for people with serious mental illness as part of their routine outpatient mental health care. The first phase of this programme involves several pieces of work to build our evidence base to go into our intervention development box. I want to talk about just one of those pieces of work very quickly, because it's my favourite. We're analysing real consultation audio recordings taken from the MASK trial of clinicians offering patients an e-cigarette. Using a sociolinguistic approach called conversation analysis, our qualitative researcher, Xin, is studying how doctors talk to their patients about their smoking. What kinds of words, grammar, or interactional strategies make it more likely for a patient to accept the offer of an e-cigarette, and how can we support clinicians to respond if a patient resists? Effectively, what makes the conversation smooth and avoids a bumpy conversation? We want to build our communication guidance not on what we or what clinicians think works, but what we can demonstrate with evidence works. Because as communication analysts, we know that communication can often be a little bit counterintuitive. Of course, for many people with serious mental illness, they cannot even imagine reducing their smoking. So alongside the very brief advice and offer of an e-cigarette, we'll also be offering ongoing behavioural support. And this behavioural support programme was something that was developed and tested as part of the Scimitar trial. Let's quickly dip into our intervention box. So drawing together our various development work, Xinxin's conversation analysis and her qualitative findings, Ethan's, our research assistant's umbrella and scoping reviews, insights from our PPI panels, we'll investigate our intervention in a clinical trial next year. We want to find out, is running a trial in this context possible, and whether our intervention is effective. And as is usual in programme grants, there'll be an embedded process and economic evaluation, which will help us understand and explain the active ingredients of our intervention, and also help us to figure out whether a smoking reduction intervention can be implemented and sustained as part of routine outpatient mental health care. Thank you.
Great, thanks so much, Nicola and colleagues. Absolutely fantastic. So we've got a couple of minutes if there's any questions anybody wanted to put to the team. Prabhat, yeah.
Thank you for that.
Just for colleagues online, the mic's important. Yeah.
Thanks, Lucy. I think it's on. Could you elaborate on the trial outcomes of a reduction in smoking versus quitting? And we know clearly that quitting is the only thing really that would have health benefits. But could you elaborate on both the mask result and also what your endpoints are?
So we know from the mask. Can anyone help? Yeah. So we know from the mask study that our outcomes, our primary outcomes were actually reduction and cessation. But what we found was, that more people in the e-cigarette group were more likely to reduce than the control arm. At our 6-month follow-up, we found that there was no difference between groups, and very few people actually went on to quit. But with the mass trial, the difference between that and the Trident programme grant is that there's a lot more support with the Trident programme grant because behavioural support wasn't offered in the mask study. So we suspect that to get people over the line, to get people maintaining their reduction, providing that package of support, behavioural support in particular, may make that difference. So that's where we are with designing the Trident programme grant, is that we are focusing on what can we do to maintain that reduction so that eventually it does lead to quitting.
Okay, maybe time for one more question just behind.
Thank you very much. Super presentations. Thanks for that. As a GP, I've got a question. Brief interventions. Now, we as GPs intuitively think that a brief intervention would be most effective at a time when the patient is receptive. In other words, somebody is coming with a cough and you say, well, actually, if you weren't smoking, the cough would last less time, for example. Some of our colleagues take the view that that isn't the appropriate time for a brief intervention, but rather it should be done in isolation. And I'd be interested in your views on the evidence on that.
Okay, Nicola?
So there's definitely some work that shows that people's motivation is incredibly fluid. So there was some work done in the US by colleagues at the University of Vermont where they actually mapped people's motivation over days. And, some people made a quit attempt, some people didn't. And what was found in a lot of cases were people would just make impromptu quit attempts. They might not have even been thinking about it the day before. So that's where the kind of principle is, well, if we can slip it in at any particular moment, we catch as many people as we can, because although outwardly people may not seem that motivated, or it might not seem as related to why they're coming, actually we might just catch people. And we know with smoking cessation that the kind of economic impact of people quitting is enormous, even very small numbers. So we're kind of very interested in, even if, okay, it's only going to be 1 or 2 people in this period of time that do make a quit attempt, it's still very much worth it. So, yeah.
Great. So really this was just to kind of whet your appetite. There are a number of posters up where lunch will be served, so please do look at those as well. But great to see the range of work going on, the range of methods being used. Fantastic. OxTAG team, thank you. Okay, so now to the headline act. So absolute pleasure to welcome Professor Sir Richard Peto. Richard is Emeritus Professor of Medical Statistics and Epidemiology here in our Nuffield Department of Population Health. He's also Emeritus Fellow at Green Templeton College. So I had the pleasure of sitting down. Richard took me for lunch at GTC a few months ago. Got to know him a bit. I think, Sarah, you described it as being petoed. But absolutely fantastic, really, to spend a bit of time with Richard. So Richard studied natural sciences at Cambridge and then went on to read statistics at Imperial College. He moved to Oxford in 1969 with Sir Richard Doll and has been here since. really phenomenal contributions in all sorts of fields. So systematic reviews we've been sort of discussing. Great that Ian's here, really a father figure in this area. But Richard, really kind of led the development of the whole field of meta-analysis. Such a valuable contribution. A major contribution about doing simple, very large randomized controlled trials. And these are traditions that continue, not only through Nuffield Department of Population Health, but I think also now in similar departments across the world. So absolutely fantastic. So RCTs of treatments for all sorts of kind of interventions in cardiovascular disease, cancers, etc. But I think for what is most well known, certainly to me at least, is the phenomenal work around the harms associated with tobacco and the benefits associated with tobacco cessation. So he's been honoured and recognised in all sorts of ways, including a member of the Royal Society for his work on meta-analysis, knighted for his work on the epidemiology of tobacco-related disease and cancer prevention. And it's in that vein he's going to be speaking to us today on the subject of tobacco deaths, the past 75 years and the next 75. So Richard, very, very warm welcome. Thanks for doing this.
Okay. Well, we'll start with one correction to the intro anyway. Meta-analysis got introduced by a number of different people independently, and we're lucky to have Ian Chalmers here, who led the Cochrane meta-analyses and developed an independent stream. And there were some Americans who were also developing a method independent. It was just bound to be discovered around that time because it was increasingly necessary. And as for the preceding talks whetting your appetite for my talk, I must say they whetted my appetite for just going back to tobacco and stopping the other things I've been wasting my time on. Okay, the past 75 years. Why the past 75 years? Well, it's because in 1950 was the big bang when suddenly the evidence on smoking became, no, I was told, yes, there was a laser pointer, good. When the evidence on smoking became conclusive, where in retrospect, there was evidence before 1950 that should have been regarded as strong evidence, but it wasn't. And if you look at the medical textbooks of the 1940s, late 1940s, you really don't see smoking taken at all seriously. There's just nothing there at all. There's vague things about lip cancer, which was thought because with pipe smoking, it was thought because it was burning your lips or something. But there was nothing serious in the textbooks. It wasn't known. Then in 1950, 5 papers came out at the same time on smoking and lung cancer, and 2 of those were really good papers, Richard Dole's and also one in America called by Winder and Graham. And these really, even without those 2 big papers, the other 3 papers that came out in 1950 should have just said, wait a minute, this is real. Okay, so let's go on to the evidence. So discovery of the main tobacco hazards, 1950 and onwards. So I say 1950 was for lung cancer and then other diseases, major diseases during the 1950s. Lung cancer was assessed retrospectively, talked to people with lung cancer, find out what they did, what jobs they did, what they smoked and so on. And the thing that just jumped out was that nearly all lung cancer was among smokers. And that jumped out in America, in Britain, and in retrospect, there have been some previous studies which were smaller and not as good. But when I asked Richard Dole, how many lives he thought that 1950 paper of his had saved, he said none. It was bound to be discovered round about then. The only reason it was delayed so long was because of the chaos of the Second World War. And I think actually where he did save lives was by helping people to understand the evidence when it came out, because there were some complexities in the evidence that caused a lot of misunderstanding. The key one being that if you really want to kill yourself by smoking, you've got to smoke a long time to do it, isn't it? You're sort of starting, say, smoke young and then smoking 20 years and then stopping, you'll probably fail. But if you wait till you're 40 and then start and then smoke for 20 years, you'll probably fail. But if you start early and continue, then you've got more than a 50% chance of success. So, anyway, lung cancer. Then in 1951 and in 1952, in Britain and in America, a couple of reasonably big prospective studies of smoking began. These were bigger than any previous prospective studies. And clear results on lung cancer were published already in 1954 from a British study done by Doll and Hill. So 40,000 doctors with follow-up from 1951 to 2025. 99% of them are dead now, and Hong Chau Pan, who's co-author of this presentation, actually has followed them all up. Fewer than 1% have got lost in the intervening 75 years. And Kyler Hammond set up a study of 180,000 US men. He actually set it up because he thought all this stuff about smoking and lung cancer was rubbish, and he was going to do the epidemiology properly and prove that it was rubbish. So he asked 180,000 men what they smoked. It was men that were getting the lung cancer in those days. Women came later in the US. And he suddenly realised, wait a minute, this is real, God. And so he became one of the best tobacco epidemiologists in the States for some decades. But he did it. He set up his study to disprove the hypothesis, whereas Doll and Hill set up theirs to check the lung cancer evidence, which they were sure was right, and also to find out whether other diseases were also caused. But anyway, they both came to the same conclusion and came to it fairly rapidly. And then later on, as I say, if you want to kill yourself by smoking, you've got to do it for a long time. And so studies that came later could look at the effect of really prolonged smoking, lifelong smoking, and see really big risks. And in the 1960s, in the 1980s, the 1990s, there were 3 studies, each involving 1 million adults, prospective studies. In the United States, Cancer Prevention Studies 1 and 2 from the American Cancer Society. In Britain, the Cancer Research UK, well, NDPH, Million Women Study, Valerie Brow's study. It's the best study of smoking and death in women. It started around about 1998 and it's still continuing. This is women born around the same time as me, so it's my generation. And this was the first generation where women were really smoking seriously from their teenage years. I remember back in the 1950s, people a bit older than we teenagers would look down on women smoking in the street as being common, which was a nice euphemism for something. And anyway, and then it just became normal, unfortunately. And so we finished up with my generation of women, those who do smoke, finish up with, really high rates, much higher than their mothers would have done. Because my generation, the women, when they smoked started from their teenage years. Mind you, lots of them stopped and produced a very nice natural experiment demonstrating the efficacy of cessation, not the efficacy of sensation. Okay, there's the research, but to what extent did people actually believe it? And the answer is researchers believed it in the 1950s. The medical profession got round to believing it in the 1960s, but the general population didn't really get round to believing it until the 1970s or later. And governments didn't get round to believing it until later than that, even if they said they did. So acceptance of the main hazards. Lung cancer was accepted first, although even that, when I started working with Richard Doll back in the 60s, there was a lot of argument as to whether this really was a cause and effect relationship. There was still a lot of argument like that. And the tobacco industry always wanted it to be the great smoking and health debate and insisted that whenever there was anybody talking about the hazards, there had to be balance, i.e. somebody from the tobacco industry saying, no, this isn't true on the same programme. But anyway, a big change came in 1962 when the Royal College of Physicians, actually for the first time in several hundred years, actually did something political. And they actually issued a strong report on smoking and health. And it was the first publication from the Royal College of Physicians that ever sold well. It sold something like 50,000 copies, more in America than in the UK even. And it was the seed for the Americans. The American Surgeon General, a guy called Everett Koop, finished up deciding that we ought to do this in the US. And so he appointed a panel that was supposed to be completely independent. He allowed the tobacco industry to vet everybody for independence. And then they sat and debated the evidence. And journalist was talking to one of them while they were debating it and said, well, come on, this is obvious. I mean, the guy said, yeah, of course it's obvious. We've got to actually go through this impartially. And the journalist reported this, and the guy was just fired that day and replaced by somebody acceptable to the tobacco industry who wouldn't do that, but who was also acceptable Surgeon General. And they came up with a very clear statement that this is real. All the bad things the Royal College of Physicians said about smoking are true. And, from then on, there was acceptance, quite wide acceptance in the medical profession that this was real, increasingly strong, but it wasn't emotionally there. It wasn't really emotionally there in the way it is now. Anyway, over the next half century, it was progressively wider acceptance, first in developed countries and then worldwide. And you can see this sort of changes if you just look at UK cigarette sales. This is men and women together, so I really should get men and women separately, but you can't really separate them early on. All we know is how many were sold. So here is cigarette consumption starting from 1890. So here we've got something like 130 years of data. So there's the increase in cigarette smoking starting in the 1890s. There's a blip for World War I, a bigger blip for World War II. Then there's a decrease when the Labour government had to put prices up because they were running out of money after World War II. It was an expensive business. Then you get these little kinks here with the UK physicians' report and then the UK Surgeon General's report, but carried on up. So by 1973, after about 25 years after research on lung cancer and smoking had begun, consumption was actually considerably higher than it had been. And then the Conservatives government came in and they got some economic theory or other called monetarism, which said that if you gave lots of money to the rich, then everything would go well. And so they finished up with a lot of unemployment and economic crisis, and they got rescued by the Argentinian generals. But in the process, they had to put the price of cigarettes up. So they put the price up, and once they put the price up, consumption drops. You see, you get two nice drops in consumption, one with the Labour economic crisis here, and the other with the Conservative economic crisis there. And it goes on and on, down, down, down. So now it's down. It's gone down by more than 3/4, and still falling. And in the States, the decrease has been even bigger. We're down to about 10-12% smoking in adults now. It's projecting slightly forward from the last survey. Whereas the Americans went from 11% in 2009 down to 5% now. It's extraordinary, the change. And it's only the ones who were high school dropouts who are still smoking pretty well. And this is first in males, then in females, because the increase in smoking was first in males and then in females. So 1950 minimum, that's when you get clear evidence published, and there's the response to the clear evidence. In 1973, when they start banning TV adverts and start restricting advertising and introducing plain packaging, putting the price up. And it's a success in 2 countries. Or you can describe it as a failure. I mean, still it's causing more cancer deaths than all the other reliably known causes of cancer put together in this country. So maybe after 75 years that's a failure, I don't know. But anyway, you can avoid more deaths by a moderate reduction in a big cause than you can by a big reduction in a small cause. But here's the lung cancer mortality for the UK. This is lung cancer mortality in middle age. Men at the top, women at the bottom. The women never hit the highs that men had hit because the women cut down on smoking. But if women smoke like men, they die like men. That's really, that's basically the conclusion from Valerie Brow's study. But since they started later, then the smoking cessation came in and actually avoided the big increase in female deaths that would have been seen. So that's the pattern. I don't know whether it's sort of optimistic in some ways and then sort of bloody dismal in other ways when you think of how many stupid deaths this is. And here's a similar picture to the US. See, we got up to about 6.5% of the men at the death rates of 1960s. Would have actually, I'll tell you how I should have plotted this. This is where I started working on it. See, that's it. That's it. That's what it is. Okay, well. Okay, maybe I'm not the failure I thought I was. Okay, and here's the same thing for the US, but you notice that the scale's different. In the US, the men never got above 5%, but here's the same picture for the US. It's the same sort of picture. And the females got up to a sort of higher fraction of the male maximum. But it's both down quite a lot. Still, in America and in Britain, it's a lot of the deaths. Okay, now, and of course, this is just one disease. Smoking kills, that also causes a lot of other types of cancer. Cancer of the mouth, esophagus, pharynx, larynx, pancreas, bladder, various other odds and ends. The renal pelvis, actually. But and also causes death from vascular disease, death from respiratory disease, particularly emphysema. But so it causes more deaths by other diseases than by cancer. So it's still a monster. But the good news is that it used to be worse. And I want to come down to this oddity that the excess risk is much, much greater with prolonged smoking and actually prolonged use of cigarettes. I mean, why? A lot of tobacco was smoked in the 19th century, but very little of it was cigarettes. I mean, there's a famous Van Gogh skull, which was a cigarette in between the teeth. But in general, it was pipes and cigars in the 19th century, and it really didn't produce anything like the amount of disease, certainly of cancer, that the use of cigarettes did. And exactly the reason for that, I think, is still interesting. I don't know why it is. I mean, you can say that, okay, you inhaled them rather differently than smoke from pipes as alkaline, so you get the nicotine through the oral mucosa, so you don't have to inhale it. And maybe that's true. Anyway, the odd thing is that the annual excess risk in smokers is approximately proportional to the fourth power of smoking duration. And the fourth power means that if you double the duration, you don't double the annual rate, you double it and double it and double it and double it. So you finish up with 16 times the annual rate. So the excess after 40 years of smoking turns out to be 3 times as big as the excess after 30 years of smoking. And this has some odd consequences. It means that it's only when you get the teenagers starting to smoke that you're going to see the really high rates half a century later in middle age and in old age. Actually, after a nationwide increase in cigarette smoking by teenagers, there may be a delay of about 40 and then 60 years before the main effects are seen on lung cancer rates at ages 55 and then 75, because obviously it takes you 40 years to go from being 15 to being 55. And so, for example, Franco died in Spain back in the 1970s, and under General Franco, Spanish women didn't smoke. And so after Franco died, suddenly the women could smoke. It became socially acceptable. They were going to be like Europeans, and they were going to die like other Europeans. And so we had this weird situation in 1990 that 3% of the women aged 60 were smoking, but 50% of the women aged 30 were smoking. But there was virtually no deaths from smoking at that point in Spain in 1990. And then, as an obvious consequence, we're now seeing the increase in lung cancer in those women who were 30 in 1990. So we're seeing this as a delayed result of the changes in smoking triggered by Franco's death half a century earlier. So it's counterintuitive, and this muddled a lot of people, actually, not realising the duration. And that's one of the things that Richard Doll really got right and really explained back in the 1950s, Doll in collaboration with Peter Armitage. And so an example, US male, then female cigarette smoker lung cancer. And there's a beautiful study by Mike Toon and his colleagues of what was seen in 3 big prospective studies, one in the 1960s, one in the 1980s, and one in the 2000s in the United States. Actually, the 2000s one was a meta-analysis of smaller studies, but it's the same thing. And it's really interesting. So here you can see the epidemic evolving. This is done for men, women on the left, men on the right. And on the left, you can see the red is the lung cancer death rates among smokers in the 2000s, among American women who smoked in the 2000s. And, it starts off among women in their early 50s and early 70s, and then in their 80s. So that red line is what's seen now in the United States among women who smoke. But when in the 1980s they did their million person study, half of them were women, then they found lower rates of lung cancer in the old smokers, got the same rates in the middle-aged smokers, women in their 50s and 60s, but then lower in older women than would be seen nowadays, because in the 1980s, the older women hadn't been smoking all their adult life. By the 2000s, the smokers had been smoking all their adult lives. And when they did their study in the 1960s, you get that black line. You see, there was almost no excess of lung cancer among American women because they'd started around about the Second World War with these social changes of the Second World War and the end of the Depression. And in men, there's a similar story, but it was more advanced. So in men, eventually, the risks among men and among women, the lung cancer risks among those who smoke are pretty similar. If women smoke like men, they die like men. So the red is what's seen in American men, and the blue is what was seen in American men in the 1980s. In other words, the 1980s, right up to about 80 years of age, this is 75 to 79 here, the American men, the smokers, were already getting the full effect that you'd expect from lifelong cigarette smoking. But in the 1960s studies, the men weren't getting the full effect the men who were smoking in the 1960s weren't seeing the sort of risks that would be seen 20 years later. So this shows this long delay between cause and full effect. It's just, and you need to put this against other sorts of, other types of cancer. So in America, here's US male. Males don't have breasts, so I've left the females out because they got breast cancer coming in, which complicates the story. So US male cancer mortality trends in middle age, 35 to 69. I define 35 to 69 as middle age. I looked it up in the dictionary actually. It's a lovely piece of dictionary writing. Middle age in the dictionary is defined as that period between youth and old age. Wait, that period between youth and old age, variously reckoned to suit the reckoner. I love that. Anyway, I'm choosing it to be that age because I want these deaths to be at ages young enough that governments care about them. I'm 82, so actually governments may give lip service to this, that, and the other thing, but actually the sooner 82-year-olds die, the better for the GDP. Okay, so there's the trend in lung cancer. This is from 1950 to 2015. So there's the trend in lung cancer mortality in the United States. In Britain, you'd have a higher curve than that, of course. And then colorectal cancer, and it's going down, better treatment partly. Prostate cancer, also better treatment. Stomach cancer going down, I don't know why. It used to be a major killer back in the first half of the century, but it's gone down for strange unknown reasons. I like that decrease in colorectal cancer because about 7 years ago, I had colorectal cancer. It spread to my lungs. I got stage 4 cancer. I'm going to die. But 20 years ago, I would have, but I got NHS chemotherapy. And it turns out my body is so unhygienic that even cancer can't survive in that. And so, we just got given NHS chemotherapy and it was, well, there you are. I've got an Indian summer of academic life. Anyway, here's women. And there you've got, again, lung cancer in American women. The scale, of course, is different. I mean, the men would have been way through the roof on this scale. Anyway, there's lung cancer in American women, up then down. And there's breast cancer. And of course, that big decrease since 1990 is just better treatment, earlier diagnosis, better treatment. Then you've got this decrease in colorectal cancer, decrease in cervix cancer because of screening, and stomach cancer, again, unknown reasons. But I mean, obviously, it's dominated by the trend in lung cancer and then the improving treatment of breast cancer. Okay, so coming back to smoking, if we take the US and we then say, what should US cancer rates have been, again in middle age, what should US cancer rates have been if nobody had ever smoked? So we've got men on the left, and that sort of slowly decreasing line is roughly what things should have been like if nobody had smoked and we just got the sort of improvements in treatment that we've had. It would have been not very overwhelming. And then this is the extra that was added by smoking. So you see, back in the 70s, 80s, half the American cancer deaths, half the deaths in middle age in men in the United States, tobacco was a cause of half of those deaths. And here's the same thing in women. It's gone down. I mean, you've got this decrease in cervix cancer, decrease in stomach cancer. I mean, that's what female death rates would have been like if nobody ever smoked, and that's what was added to it by smoking. But it's still, by 2015, it's more than 20%, well, it's about 25% of all the cancer deaths. And here's the same thing for Britain, even more extreme. There's the same thing for Britain. You see, back in the 1970s, about 60% of UK cancer deaths, this is what death rate should have been, and this is what got added to them by smoking. It's crazy. And here's in the women, that's what female cancer death rate should have been, that top line there, going down because breast cancer treatment's so good, partly because of that, that's the biggest single reason. And then that's what's got added to it by smoking. So, it's just it's the magnitude of the effect. Okay, don't ask whether things are risk factors, ask how big those risks are. It's the size of the risk that matters. It's not, I mean, there's thousands of risk factors probably, but if you don't know of any of them that are as big as smoking at the moment. If we have a nuclear war, that'll be different. Okay, so UK prospective studies of maturing epidemic in men, then in women. So this UK doctor study in 1951, Richard Doll and Bradford Hill asked all the doctors in Britain what they themselves smoked. and then wrote the results up in the British Medical Journal, and the doctors read it, thought, my God, this doesn't just kill patients, this kills doctors. This is really, and so the British medical profession became the first lot of doctors in the world that actually believed the evidence. Closely followed by the Dutch, actually. So 10-year results published in 1964, then the 20-year results in 1976, 40-year results in 1994, 50-year results in 2004, a year before Richard died. I'll show you a photo of him at the press conference for those results soon. It's a year before he died. And yes! And the 70-year results are going to be published, it says here in 2024, 2026. I meant to alter this slide. But 99% dead. And then we've also got the UK women's study. So this is a study in British doctors. And the nice thing about them is they've been followed through now. These doctors were all born before 1930, so by now, 2025, they've all been followed through to 95 or more. But you can look at the death rates among doctors born in the 1910s, 1920s, 1900s even, and it just gets worse as the generations go on. Probably the ones born in the 1920s probably had the worst death rates of any cohort. Okay, and then there's the UK Million Women study, which was begun in 1998 by Valerie Burrell. 10-year results were published 2013. And again, what we were going to do, this is ridiculous. I gave this a talk like this 2 years ago, and I just pulled this slide out of it. 2024, going to be published in 2024. What instead happened was that they spent all their bloody time doing grant applications and getting them refused because this study is too boring. So they spent 2 years doing grant applications, and now we're going to write the results up. Okay, some of Valerie's study results. This is the Million Women study, and it's the best study of smoking death in women. It's lung cancer. So there's the never smokers. And even the light smokers, ones who are smoking 5 or 10 cigarettes a day, had 10 times the lung cancer risk of never smokers. Ordinary smokers, on average, had 22 times the risk of never smokers. And then the ones who were smoking 20 a day or more had 36 times the risk. And still the tobacco industry was denying that this was a real cause and effect relationship. Now, the relative risks in China aren't as extreme, but the absolute risks are quite substantial if you look at those who actually started in their teenage years, which basically means men born in towns of China. But the trouble in China is that you've got quite high lung cancer rates as background rates, probably because of the exposure to smoke from cooking. You cook over a wok, you've got the coal smoke coming from just around the wok going up your nose, and then the burnt fat coming from inside the wok going up your nose. And you finish up with quite a lot of lung cancer, even if you don't smoke. And so the relative risks aren't as extreme, but the absolute risks are quite extreme. I mean, China's going to have a lot of tobacco deaths, which China already has. Now, a little bit more on relative risks. This is the relative risk for 20 a day versus never smoked. And if you look, so here we've got just none, less than 10. This is the graph you just saw with 35 as the relative risk for top group. Then you look at it by histology. Sorry, I can't even read this myself now. Never smokers, relative risk of 1. This is relative risk of 20, 40, 60, 80. So you've got, this is just for small cell, squamous cell, large. So the small cell cancers, these are the ones that famously get caused, but people used to claim that adenocarcinoma wasn't caused by smoking, but actually adenocarcinoma of the lung actually get a relative risk of 15 if you smoke, if you're smoking 20 a day. So this idea that smoking doesn't cause adenocarcinoma of the lung and that the adenocarcinomas we're seeing now are because of something other than smoke, I don't think that this is correct at all. So yes, the relative risk is more extreme for squamous. The relative risk is less extreme for adeno, but still a 15-fold relative risk for heavy smoking, and 10-fold relative risk for just average smoking. It's not true. It's causing both types of lung cancer because a lot of nonsense gets talked about adenocarcinoma nowadays being more important than that, and that's said not to be due to smoking. Okay, what about stopping? Well, again, the women were pretty good because you could look at women who'd smoked seriously and stopped at 30, stopped at 40, stopped at 50. And you can see there's the lung cancer as a fraction of what's seen in the continuing smokers. And even if you stop at 50, you're avoiding more than half the risk you would have in old age. stop before 40, preferably well before 40, you'll avoid more than 90% of the risk. I'll run through these things a little bit faster, I think. Apart from anything else, there'll be lunch coming. But anyway, this is then all-cause mortality, relative risks in the men and women study. And here, look at the light smokers. The light smokers, the ones smoking 5 or 10 a day, they're twice as likely to die in middle age as the non-smokers, as the never smokers. You know, smoke about 15 a day, 3 times as likely. Smoke about 20 times a day, about 4 times as likely to die in middle age. And again, people say, oh yes, but then lots of things give you heart attacks. You know, those, you know, what about adiposity? What about the stress of modern living? Well, you know, and there's all this stuff about stress and, you know, do you have a lot of responsibility in your job and so on, are you? And so Valerie also asked the people if they were happy and asked them if they were stressed and this and the other thing. And actually, there's absolutely no difference at all. And so, you know, these things are claimed to be important and they're not. You mustn't mix up big causes with small ones. Here's Valerie's graph. Here's on the right is what you just saw, smoking, you know, how many cigarettes a day do you smoke? Then on the left is, are you happy? Well, relative risk of 1.0 for those who are happy most of the time. And then those are 1.0 for those who just say usually. Then sometimes, rarely or never, still a relative risk of 1.0. I mean, look at the difference between those two graphs and tell me that stress and happiness and so on is what really matters in life for avoiding heart disease. But it's, you know, just bloody urban myths, urban myths, urban myths. And there's ex-smokers again, just like lung cancer. You know, stopping works even at age 40 or 50, but stopping at age 30 is better. I'd say better, actually. I'm an epidemiologist, and actually epidemiologists need smokers much more than smokers need epidemiologists. Right. Okay, I'll move on a little bit. This 70-year follow-up. So 99%, 98, by the time that this was done, we got 98% dead. We've got 99% dead now. And about 1% was definitely still alive a couple of years ago. And so fewer than 1% got lost to follow-up. And the aim is to affect lifelong effects of cessation. What we can do, because these doctors were asked back in the early 1950s what they smoked, they've been asked every few years ever since. You can follow through, look at those who continued to smoke, look at those who never smoked, look at those who stopped at various periods, and you can see what happened to people who smoked seriously and then stopped seriously. But you've got to do it, to do that right, you've got to do it in the generations, the birth cohorts that were really seriously affected. And that was the ones that were most affected were the men born around 1920. You know, born in the 1910s, like Richard Doll, or the 1920s. You know, they went into the British Army for the Second World War and got free cigarettes. And so at the age of 18, suddenly they've got bored out of their skulls and nothing to do but smoke, and their cigarettes are really cheap. It was one of the few things they could actually pay the troops with, because we were running out of money during the Second World War. And here's, for doctors born in the 1910s, 1920s, here's the effect on survival from age 40 of having stopped smoking at about age 30. So down the bottom, so along the bottom you've got age, so that dotted vertical line is age 70. And then the lower line is the mortality pattern among those who continued to smoke until the last time they were asked. We extrapolated it forward 10 years if we didn't get another answer from them. Then there's the never smokers, and then there's the ones who stopped about 30, that's the dotted line, and they're pretty well as good as the never smokers. You say stop at 40, it's not, but stop at 30. You're gaining 11 years of life expectancy. And even if you stop at 40, you're gaining about 9 years of life expectancy. So it's good to be able to, and these people have been followed through, all of them have been followed through to age 95. Okay, so 2020 conclusions for male British doctors. This is from a talk by Hong Chow, actually, on his analyses of the 75-year follow-up. The persistent cigarette smokers lost about 11 years of life expectancy. Even cessation at age about 50 was halving this loss, but cessation about 30 avoided virtually all of the loss. And I'll go back to this, this business about, oh, my grandfather smoked till 90 and he was all right. Well, okay, let's look at people age 90. There's the never smokers at 90, and there's the continuing smokers at 90. And in the smokers, 5 out of 6 of those who would have been alive at 90 at non-smoker death rates were dead. So that's 5 out of 6. It's not that a lot of grandfathers make it to 90. And even these ones, I'm not sure that they all smoked as much as they said they did. Right, so... Okay, so what about numbers? Now, I'm using this term developed countries, which is a 20th century term, rather than high income, low income. And it's because in what were classified as developed countries, we've actually had deaths counted reasonably well by cause for quite a long time. And so we can try and estimate, and we look at lung cancer rates in general. And in the developed countries, the never smoker lung cancer rates seem to have been consistently low in populations that didn't smoke, similarly low in males and females, and approximately constant. There isn't any big increase, there isn't any big change in lung cancer rates in never smokers, when the increase in lung cancer is confined to smokers. So it's not evidence of generalised environmental pollution. So if this is true in developed countries, then the absolute lung cancer rates in a country where you don't have any epidemiology can be used to estimate how hard tobacco's hitting the population. And so it'll give you not only the tobacco-attributed lung cancer mortality, but also it'll give you some guide as to what fraction of the heart attack, of the respiratory mortality. I mean, if a country's got never smoker lung cancer rates like Spain in the 1990s, Spanish women in the 1990s, then they're probably not getting hit very much in terms of heart disease or respiratory disease either. So you see, you can use the tobacco lung cancer for two purposes. First, to pick up, is there a lung cancer epidemic here being caused by smoking? Second, what fraction of the heart attacks and respiratory deaths in that country should we put down to tobacco? And you calibrate this from the big American Cancer Society studies. And so we can estimate long-term rates and trends fairly crudely, just from for overall tobacco-attributed mortality, just from national mortality statistics by sex, age and cause. And here's the result of this if we do it for the UK. So back in 1970, that's my first year here, 39% of the 35-year-old men, 35% of the men reaching middle age would die in middle age, 35%, 39%, and 22 of those 39 deaths, this is all-cause mortality, 22 deaths, this shaded bit is the tobacco deaths. So 22 of those 39 deaths would have been tobacco deaths. And you see that during the 50s and 60s, overall mortality was staying roughly constant because medical progress was being completely counteracted by the increasing effects of tobacco in men. And then since then, we've got the decreasing effects of tobacco and we've got medical progress. And so we go down, 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 and overall mortality goes down. But the chief thing that's driven overall mortality down actually is the decrease in tobacco deaths. And improvements in medical progress are really important. I mean, if we had only that, we'd have progress. But the key thing that's been driving it has been the decrease in tobacco deaths. And here at the bottom, you can see COVID. That's that blip at the bottom. See, it's not very big. I mean, in this country, we had 200,000 COVID deaths in the 4-year period. We also had 200,000 tobacco deaths, and there were no news articles about tobacco. And there's no inquiry there's no government inquiry going on as to what the government did about tobacco. And in the world, in the COVID pandemic, we had 20 million COVID deaths and 20 million tobacco deaths in those same years. Okay, there's the picture for women. They got away with it really because they stopped smoking before it really hit them in Britain. So worldwide, world annual tobacco deaths. This is now all ages, not just under 70 deaths. Developed countries around 2 million by the methods I just outlined. That's about 1 million in middle age and 1 million in old age. China, about 1 million. India, well, work that Prabhat and I did suggests about 1 million. Other studies, I think, suggest somewhat fewer, and it would be nice to get more evidence on India. But it's a substantial number. And so I put it down as 5 or 6 million. The global burden of disease puts it down as about 8 million, but I think they're overestimating some things. For example, they're putting down a lot of tobacco deaths in Chinese women, which is just absolutely not plausible. And I think there's a tendency for the most extreme estimates to be the most widely cited. And I think with tobacco, 5 million's enough. That's 100,000 deaths last week, 100,000 deaths this week, and 100,000 deaths next week. That's enough to do something, justify doing something. It'll probably double by mid-century, chiefly due to population increase, because in some countries the tobacco death rates are going down, like UK, US, quite a lot of developed countries. but in China they're going to go up, really, I think, due to population increase. A lot of people, people are getting to the age when you're going to get killed by tobacco if you smoke. And that says if current smoking patterns continue, and current smoking patterns worldwide are that about 50% of the young men and 10% of the young women start to smoke. That's 30% of the young adults. And that most of them will keep on and won't stop. So if that carries on, then we're really going to have a bad century for tobacco deaths. So how many tobacco deaths this century? Well, probably in the 2000s, 2010s, we had of the order of 100 million. I mean, that's 5 million a year for 20 years. There'll be another 250 million before 2050, something like that. And then it's going to be running at more than 10 million a year if we keep on with what you'd expect. And these ones dying in the second half of the century, these are the kids of today. And a lot of them's already smoked. So we're talking about, in total, of the order of 1 billion tobacco deaths this century, compared with something like 100 million, 0.1 billion last century. It's just ridiculous. And then, what could be done? Well, actually, the stuff talked to you before I started is quite good. Preventing children starting to smoke is obviously a good thing if it happens, and it can avoid a lot of tobacco deaths after 2050. But if we want to do anything about deaths before 2050, we want to actually encourage adult cessation. Actually, for the third quarter of the century, a lot of those will actually, we need to get, there'll be adults who are already adult now, dying in the third quarter of the century. We need cessation. And obviously not starting is better, but if you've started already, then the fact that not starting is better is irrelevant. And a culture where adult cessation is usual will also help today's kids. It's a mistake to concentrate on whether kids start. You've got to actually help adults stop, as well as whatever you can do. Okay, now it's the relative importance of things. I think this talk is unbalanced, and this is the only slide where I'm going to be talking about the relative importance compared with other causes of death. Smoking and obesity will continue to be major causes of non-communicable disease. They are big. Smoking is big, it will continue to be big, and you can avoid tens, hundreds of millions of deaths by making it smaller worldwide. Obesity, we did have 10% obesity in the 1970s. Now we're around about 30-odd% obesity and about 50% in the US, and it's causing diabetes, blood pressure, dyslipidemia, and so on, a lot of heart disease, and it's stalling the progress in vascular disease mortality that had been being made till 2010. So these are big things, but one mustn't confuse big things with other causes that may well be much smaller, which I think get exaggerated. Now, you talked about vaping in the talks before me. You hear some saying, oh, vaping is just as dangerous as smoking. I don't find that at all plausible, and there's certainly no good evidence it's true. It may well be causing, long-term vaping may well cause quite serious, say, lung damage. I don't know. Passive smoking, the global burden of disease estimates 1.5 million deaths a year for passive smoking, 1.3 million a year. This is nonsense. I mean, there's plenty of evidence that passive smoking is nothing like that. It gets greatly exaggerated by those who want to control tobacco consumption, and it's useful for encouraging legislation that may actually have the indirect effect of helping smokers to stop. But so much of what is said about the hazards of passive smoking is untrue, and I think we shouldn't do this. I think we've got to the point where untruth is bad politics, but I'm not arguing for truth for political reasons. I'm arguing it just because it's more fun. And then there's dietary factors other than obesity. Who knows what whole grain bread is going to do. But does it, other than as determinants of obesity, is there any evidence that processed food is of any special relevance and ultra-processed food? The answer is no, really not. Nothing good. And lots of the things that are said to be healthy foods, you look at them. I mean, in Valerie Browell's Women's Study, ask women, how much fruit you eat? Divide them up into 5 groups, you've got 200,000 each group. And then the bottom ones, the ones who eat the least fruit, actually no fruit, said they eat almost no fruit, 24% of them smoke. And the top group, 6% smoke. Will you tell me why fruit eating is apparently protective against lung cancer and various other things like that? And a lot, so all these, it's like me, well-meaning Guardian readers. We eat foods that are different from people with less education. And then these dietary factors are said to be major determinants of mortality. I mean, there was a paper, a 75-page paper in The Lancet in September, claiming that if the world would switch to the planetary health diet, then, we could avoid 15 million deaths a year. And it just isn't true, except insofar as it would affect obesity. And that is certainly not 15 million a year. So many things are claimed that aren't true. And it's stuff about ambient air pollution, chemicals in the environment, food additives, stress, well, you saw stress. And I think that, I think what's wrong is not, they did a European Code Against Cancer, and they have about 70 different things you've got to do to avoid cancer. And smoking was down under S in the middle of the alphabet. If I was running a tobacco company, that's what I'd encourage. Anyway, come back to tobacco. Okay, that was it. This is what the talk should have been about. Instead, it was about sort of history and other stuff. So a little bit. Tobacco sales right now, 900 billion a year. That's 2025 prices. That's according to statistics. I don't know if it's true or not. It's probably not far wrong. We're running about 5 trillion cigarettes a year and 5 or 6 million tobacco deaths a year, and spending 900 billion a year on tobacco. And, this got written about. I mean, the person who wrote about it most, I think, back in the 1990s was Prabhat, who's sitting here now, so I'm going to steal all his best lines from him. I mean, people are talking about something other being the new tobacco. Prabhat had a slogan saying, "No, tobacco is the new tobacco," which I think is quite a good one. So 20 years ago, when we wrote this paper, we wrote the paper 10 years ago, but looking back to the 2000s, at that time, government profit and tax on tobacco was of the order of $300 billion a year at 2010 prices. And the WHO was coming up, replacing the Millennium Development Goals with the Sustainable Development Goals. And, one of these Sustainable Development Goals was smoking going down a third by 2030. Well, it hasn't. It's stayed roughly constant worldwide. So that decrease of going down a third by 2020. Now, if the real price stays constant and smoking does go down by a third, the governments will lose about 100 billion a year, which is not big money, but it's not small money. I mean, governments are interested. I mean, America gave to Ukraine in support under Biden something like 60 billion. I can't remember how many it was, something like that. So 100 billion is of interest to governments. But if the real price doubles, then doubling the real price will actually cause a serious decrease in smoking, probably of the order of a third. And the governments would then gain 100 billion a year. So this was the experience in France, in Canada, and in South Africa. Between 1990 and 2005, those three countries tripled the real price of cigarettes. Consumption went down by half, and the government's got more money. So this way, I think this seems to me a more realistic strategy. The Chinese government produces 1/3 of the world's cigarettes. And they make a lot of money from it. And, if they tripled the price or even doubled the price, then they'd make more money from it. And we avoid quite a lot of those mid-century Chinese deaths and second half of the century Chinese deaths. So that's looking forward to the next century, to the present century, the rest of this century, the next 75 years. But going back to the last 75 years, Richard Dole, he did a nice job. It was a really, really nice job in the 1950s. First, discovering the relationship in parallel with other people, but then being the one person who really, really explained it clearly in ways that even now, looking back 70 years later, are right and are much clearer than many other people's understanding of it. And then, over the rest of the century, he was always trying to get people to see the relative importance of different causes. And that's what's needed. So I'll finish up with a photo of him. I like this photo. See, this was taken the year before the 50-year follow-up was. This is the press conference at the BMJ where he's announcing the 50-year follow-up of his life's work, and just showing the extraordinary hazards, the full hazards of smoking. So it's a nice photo. So you can actually have a good time when you're 91 still. Sometimes it's nice. So, but mind you, when he went to hospital a year later, and I went to see him every day. I mean, he knew he was dying, and he said, as he went to hospital, he said, "Look, I'm dying, and I think that that's appropriate." I thought, what? But he did. I mean, he wanted to die while he was still Richard Dole, and I went to see him a lot. And I remember I went and I said, "Look, I don't want anything else from you when you're dead, but can I have some of your flashy ties?" So, of course, they won't be any use to me. So here we are. I always wear this when I'm giving a Richard Dole-related lecture, so thank you. Okay, that's it. I don't know.
Richard, absolutely fantastic. What a tour de force. Brilliant. Got a few minutes for comments or questions. Chris.
So fantastic, exciting talk. And I first met Richard Dole when I joined Green College as a DPhil student, and the picture brings back marvellous memories. Would you say then that the two interventions that are needed are, number one, yeah, I'm trying. It's near my mouth. There we are. There we are. Yeah, it's closer to my mouth. The two interventions that would make a difference are, number one, a generational smoking ban, which affects the younger people starting, and a massive price increase to stop the older people, to encourage the older people to stop. Those are two public health interventions that are needed. If not, what are they?
Well, I think three things actually. First, I can talk about the effects of particular things like price increases and say what is the scientific evidence that they do affect consumption. And there is strong evidence that price increases do have a substantial long-term effect on consumption. They need to be accompanied by a lot of information and various other things to make them politically acceptable. You can't have price increases in general until you've actually got the health information out. So I think you need the health information to make the price increases possible. You've got to have anti-smuggling stuff. You need price increases in many different countries. So I'd like to put the scientific evidence on that together. This comes back to the talks given by other people before me. They're trying to look at the scientific evidence on various different things that could be done. And I'd like to know what could be done in different countries. I'm glad that one of the speakers before me actually did show a map of the world saying where various things were, because it is a global problem. I mean, as a statistician, the first statistic is that 99% of the world is not British. And actually, an even more amazing statistic is that 95% of the world is not American. Oh God, that's actually, no. God, I'm going to get sued for about bloody $1 billion by Trump for that. That was racist. But what are we going to do about what is going to be done about Indonesia, about China, about the switch now from beedi to tobacco in India, and so on. So I think that we just need a lot of evidence as to what works and what works in different social groups. And I just thought there was very nice perspective being shown. But one thing that didn't come up was a ban, and I'm rather doubtful about that. I don't think we've got a very good history on banning things, whether it's marijuana, other drugs, or alcohol. I don't think that. I think you can't. I think governments have got to work with what's politically possible, and I think if you've got 1 billion people addicted to something, you start banning it, you're actually going to do society quite a lot of damage. I think. You could say that cigarettes are doing society quite a lot of damage as well, so let's do it anyway. I think we've, as epidemiologists, we ought to just try to say what is the evidence about this, that, and the other thing, and leave other political processes to decide on what will be done. I wouldn't advocate a ban myself, but I don't claim to be an expert, and also it's a political decision. We should just get the evidence straight, how various things stand out, and not let big things mix with small things. So I think bans may well do harm, in the sense that, even vaccine mandates, I think, have done some harm. They've done some good and some harm. but it's you want something that'll take the majority of the population with you, and I think information, in a sense, makes you people's allies, and I think that bans makes you their enemy. You say, why are you telling me to do this? I'm not. I'm saying that didn't you hear me? I said actually epidemiologists need smokers more than smokers need it. I want you to continue.
Thank you. Thank you for the jokes. They were fantastic. I'm here. Sorry.
It's only the jokes, is it? That's it.
They're brilliant jokes. I'm interested. I'm particularly love working in a department where I know that our tobacco addiction group don't take money from the tobacco industry, and so I feel really proud that we live that as one of our values and part of our integrity. But I'm also aware that people working in this space and in alcohol addiction spaces are increasingly subject to political attack by an industry which, as you've shown us, is making a lot of money from these products. And I just wonder whether there was anything that you had support with in your long career in this space to fend off those attacks, or whether you perhaps were protected from them and didn't even have them, and whether you'd give advice to some of our younger researchers who are starting out in this space about how they can continue to work in an area that is politically and in terms of industry quite challenging at times.
Of course, you've got some commercial interest going for you when you're talking about changing from one product to another. I mean, that could be helpful. I mean, somebody who's actually making, nicotine replacement therapy. I know the big tobacco companies are making it as well, BAT, Philip Morris, but there are also some that are just producing nicotine replacement treatments, and their commercial interest actually goes the opposite direction. I think also that it's probably, the evidence on tobacco now is, I think it's so overwhelming, it's difficult for it's impossible for the tobacco industry to deny it plausibly. They can, I suppose the other thing is I don't know what is happening online. I just don't have any feel for what is happening online, because that's where the manipulation of people is chiefly going to be now and in future decades. So I think we need specialists in what is happening in terms of persuasions online. Back in the 1950s, 1960s, of course, a lot of the people in the tobacco industry in the 1950s, of course, they joined, and they could just have been making shredded wheat or something like that. Okay, they were making tobacco, but they could have been making any sort of innocent product, orange juice, shredded wheat, pillows. And they suddenly find themselves making something which is, causing lots of deaths, first from lung cancer, then from many other diseases. And there they were halfway through their careers working in the tobacco industry. Some of them really tried to advise the tobacco industry to accept the evidence. Sure, look at other evidence, sure, get it checked out. But I know the advice given by Dr. Green, who was the chief scientific officer within British American Tobacco in 1970, was that the industry had to accept the evidence, otherwise they would be held in contempt by fair-minded people. That was the internal advice they were getting. And to start with, the British industry did, to some extent, follow that advice, whereas the American tobacco industry didn't. They went for, denial, doubt it's our product, all that sort of thing. Anybody who's in the tobacco industry now knows exactly what they're joining. Anybody who's working in tobacco in advertising knows what they're joining. They will use unfair methods to influence things. The one thing I think we've got to be careful on is the economic effects, because it's claimed that smoking is costing the NHS vast amounts of money every year, which is true if you look at the number of people being treated for heart attacks, lung cancer, various other diseases caused by smoking, peripheral arterial disease, emphysema. So that costs money. But of course, in terms of GDP, smokers don't cost money because they do the economy the favour of dying. So actually, when you actually get to, let's say, retirement age, then actually what are you doing? You're occupying a house, you're taking a pension, perhaps a substantial one, you're using health services, social services, and you won't stop doing it until you finally die. And so in terms of GDP, I mean, you know, economists use these euphemisms like, you know, such and such a country is enjoying a demographic dividend or something like that. But, or, you know, demographic penalty now in China because so many people are reaching old age in China. But actually, in terms of GDP, anything that kills people after their kids have grown up and gone saves money on average. I mean, I know some people are sort of useful in their 50s and 60s, maybe even later, but you know, they sort of cost money. So it's you've got to be quite careful on economic arguments. The National Health Service has a different scoring system. See, in the NHS, they want to say, is something worthwhile, based on whether, how many quality-adjusted life years you'll get for every £1 million spent or every £100 million spent, how many quality-adjusted life years you get. And so, for example, I mean, I'll give you a simple example. In the middle of a heart attack, if somebody comes into hospital with a heart attack and the doctor gives them half an aspirin a day for a month, that'll cost nothing, 15 aspirin tablets. And there'll be something like a 1% extra chance that they'll get out of hospital alive. And if they do, then they'll probably have about 10 quality-adjusted life years. So you're getting 10 quality-adjusted life years for almost nothing. And so for the NHS, that's a bargain. Yeah, we want to use antiplatelet treatment if we've got people with a heart attack and we're not going to do anything that's contrary. But for the GDP, it's a disadvantage. So you see, what is a good thing by the NHS scoring system, in that it's giving people quality-adjusted life years, is a disadvantage for the GDP scoring system. And and the tobacco industry lobbies ministries of finance on this. I think that's one of the things that they do, which is actually quite dangerous. And I think within China, for example, I mean, the Ministry of Health wants stuff done about smoking, and a lot of the people in the Ministry of Finance don't. I mean, this was true about 10 years ago. I think it's probably still true. And actually the people who didn't were themselves smokers. They often find it very difficult to accept the evidence. So yes, there is a lot of lobbying, and I don't know enough about it. It's a very major, serious area for study, what is being done, because when you've got $900 billion coming in every year, then there's plenty of room to afford a bit of extremely devious activity. I don't think that interfering with researchers now is the main way that that's being exerted, though. I don't think that's the big problem.
Great. Richard, thanks so much. That's been absolutely fantastic. Thank you. So just before I hand over to Prabhat, just wanted to thank the team that's put this event on. So we've had Sarah and Joanna at the desk as you registered, and the events team, Lucy, Anna, Declan and Hayley. A lot of work goes into these events, so very, very grateful to them. Delighted that Prabhat, I think Prabhat, you're relieved to know you're still middle-aged and might have some use, but absolutely delighted that you've joined us today, our new head of Nuffield Department of Population Health. Thrilled to recruit Prabhat recently. So Prabhat, final words to you, please. Thank you.
Thanks. I'll just use this, Aziz. Thank you very much, Aziz and Nicola, for organizing this event. It's really important to know that tobacco is continued to be taken seriously, and as per Richard's statistics, in the last hour, approximately 600 people have died from smoking attributable conditions, and we have to keep that in perspective when we think about all the things and all the distractions about what might be studied in epidemiology. I just wanted to make three specific comments to very much thank Richard for his incredible insights, which I think many of us have benefited from for over decades. And the first was to make a comment. I'm glad he showed the last slide of Richard Dahl, but I think one of the most memorable meetings I've been to was in 2012, which was on the 100th birth centenary of Richard Dahl, was the first gathering of the Richard Dahl collaboration. And one of the focus, of course, because Richard was organizing the meeting, was on getting the evidence from various populations on the hazards of smoking. And it was a real thrill to come and see presentations from Japan, from the US, UK, other settings, particularly documenting the maturing hazards in women. And it was remarkable to see this incredible consistency of the 21st century hazards of smoking, effectively suggesting a tripling of the relative risk. And I remember that meeting as a very formative one in terms of thinking about global efforts. I'm glad Richard mentioned the importance of thinking globally, and one simple metric that you can consider is how many ex-smokers are there in a population compared to current smokers. It's a very simple metric, and if you did a map, which I won't show, but if you did a map of the world, there's actually incredible progress in that many places have more ex-smokers than current smokers, and that's certainly in high-income countries. But even in places like Brazil, because of their efforts with taxation, there's a large increase in ex-smokers. But where there's large gaps remain Russia, China, Indonesia, India, and large parts of the Southeast. That's very much the global battlefront in terms of raising cessation rates. The last point I would raise is we have to get the understanding of the benefits of quitting very broadly understood along with the hazards of smoking. So I'm delighted about the efforts that Nicola and team are leading around the benefits of quitting. And I will add just one statistic to that from our own research, that Richard talked about how much life you get back if you quit by age 30 or 40. The other part of that has come out from our own research is you get much of that back quickly. So it's not like you have to be an ex-smoker for many, many years. Even ex-smoking up till 3 years gives a large part of that long-term benefit back quickly. And I think we need to disseminate those efforts. So let me thank Aziz and Nicola again for a wonderful symposium. I know this is what I would like to be spending time on, along with Richard and Sarah and Hong Chao and others, is tobacco is absolutely a really important and imperative priority across the university and globally. So thank you again for coming, and I'll hand it over to Aziz.
Thanks so much, Prabhat. It's great to have you with us. Wonderful. So I think it's been a great session. So just a date for your diaries. On the 11th of December, we have our next guest lecture. That's Pooja Miles, who leads the database CPRD from talking about synthetic data, AI, and regulation. So if you can make that, please do. And the guy who called me as we're kind of wrapping up said lunch is available till 2. So please, that's where they're going to wrap it up. So if you want some lunch, you know where to go. But thank you very much, and thanks in particular to Richard and Nicola. Thank you.